Hi, I'm Jack Cush with Rheum Now. Welcome to our campaign on women in rheumatology, the XX Factor. This video series, our therapeutic update, is devoted to gender differences in disease and response. This is a series of videos from well-known experts in the field of rheumatology who will address why there are obvious gender differences in how certain diseases present, how they progress, how they're treated, and how they respond to treatment. It's an eye-opening collection that will feature great videos by Dr. Alexis Ogdi on gender differences in SPA and in PSA. Dr. Megan Klaus talking about gender differences in counseling on reproductive health. Anisha Dua will do the same on the topic of vasculitis. Nancy Lane will talk about, yes, there are gender differences in osteoporosis that you need to be aware of. Philip Meese is going to talk about disease activity and drug response. Jeff Sparks is going to talk about lung disease and how gender influences both presentation and disease there. I'm going to start off with a discussion of why is there a gender difference? If it happens so often and is so prevalent in so many diseases, the question is there a common thread for why this happens? In 2006, a large population survey in Spain asked people about their state of health and how much pain they have. And when the survey was done, the percentage of people who had either very poor or poor health was higher in women than in men, 39% versus 26%. Moreover, how many of those people admitted that their health and pain limited their activity? Again, much higher in women than it was in men, 26% versus 19%. The question raised then and now is, are these just complainers, or is this a real biologic phenomenon? It turns out that there is a real gender bias in healthcare, meaning we physicians don't treat male and female patients equally. Historically, it has been thought that many physicians, male physicians, tend to dismiss women with complaints, especially of pain. This has fallen under a lot of scrutiny and criticism in the last year. The buzzword of 2022 was gaslighting, especially medical gaslighting, where we tend to minimize the complaints of our patients. This is more likely to happen in women than men. It turns out it's backed up by the statistics. Physicians are less likely to give pain medicines to women. They're less likely to refer them for diagnostic services. They're more likely to give them antidepressants and to refer them for depression and mental health care. So there are these differences that we as providers need to be aware of. The question is, are there inherent differences between men and women? Some of the things for men are pretty obvious. Men tend to do worse where their behaviors have consequences. So aggression, violence, smoking, tobacco, motorcycle riding, all of these lead to both disease and injury, with obviously higher numbers of those events in men engaged in those behaviors. Men are more likely to be adherent to poor diets or adherent to no diet at all. They probably have more cardiovascular disease because they have lower HDL levels compared to women. Men have more aortic aneurysms, gout, spondylitis maybe, certainly alcoholism, bladder cancer, COPD, and ulcer disease. I guess the question is, do they cost us more since they have more of these diseases? It turns out that women tend to see more doctors than do men, but women cost less when it comes to overall cost of medical care. Women have many disorders where they outnumber men, and that would include asthma, diabetes, myocardial infarction. In some surveys, some there it's actually not. I think what's really worse in women are the outcomes, and probably that in many women it is the combination of the gender and the disease made worse by a higher rate of comorbidities. So what disease are we talking about in women where there are worse outcomes? I think more pain, poor response to therapy. So anxiety, depression, autoimmune disease, as you know, many autoimmune diseases are female predominant: RA, lupus, multiple sclerosis, autoimmune thyroid disease, scleroderma, dermatomyositis. We can go on, right? Also migraine, osteoporosis, overall thyroid disease, and stroke. Now, the reasons for women doing worse is probably very hard. And in all those videos that you can also look at on gender differences, everyone scratches at the question without necessarily giving a satisfactory answer. So I'm going to give you a listing of what's important, and maybe you can choose your own factor. So one of I think the goofiest but nonetheless interesting differences might be in the genes themselves. The difference in that one Y chromosome versus the extra X chromosome. Turns out Y chromosomes are, in fact, 1/3 smaller than an X and have less genes on them. And no, I don't subscribe to the belief that the number of genes equates to actually IQ points. That's not a reason for my bad decisions as a male. But, are there consequences to this genetic load or genetic deficiency in males versus females, or are there some protective effects there? It's hard to know. I think everyone really, instead of talking about the Y versus X chromosome, talks about sex hormones. We certainly know from a lot of old literature that testosterone has multiple protective effects, especially as it relates to musculoskeletal medicine and inflammation. Testosterone does yield higher pain thresholds, lower pain responses. It's been protective in many animal models of autoimmunity and inflammation. It's felt in general to be even almost at a therapeutic level. And then conversely, not having testosterone, having more estrogen and other female hormones is thought to be contributory to inflammation, especially at peak hormone levels, either at the surge in hormones, as might be related with pregnancy, or in maturation after adolescence. So besides the genes and the hormones, I think one of the major things that really lends to a big difference is the differences in presentations. Women are typically atypical. The best example of that is heart attacks. Men present with Levine sign, and radiating pain to the arm and shoulder. Women are less likely to have those classic symptoms and are less likely to be diagnosed with an acute myocardial infarction. So the atypical presentations is particularly evident in ischemic heart disease. We see it also as one of the reasons why there's a difference between men and women in presentation with spondyloarthritis, also with gout. We do know with myocardial infarction, women are less likely to receive aspirin. They're less likely to receive resuscitation. They're less likely to be in an ambulance that's got the sirens on and is running red lights. Yeah, there's actually research to support those contentions. And the question is, does that in fact add to maybe poorer outcomes? Men, in general, are much worse at being sick. And if you don't know what that means, ask your mother, your wife, your sister about man flu. I didn't know what man flu was, and my research coordinator told me these great stories about what happens when her husband gets a cold, but it's really called man flu because it's devastating. The world stops, and he's out of work for a week or whatever, and can't do anything. And it's obviously, the point is that men, when we do get sick, we're really good at it. Women tend to be what? Stoic, power through, continue to do it. One of the problems of women is that they often have these delayed presentations, and it shows up in a lot of different ways. Later diagnoses, they're less likely to receive DMARD therapy earlier on. They're more likely to have longer duration of disease because they start earlier, they complain less, and then they live longer. And hence, that adds to some of this. There are other reasons maybe for a gender difference. That would include higher inflammatory biomarkers, higher levels of sedrate and C-reactive protein are found in women than men. And I think that, while everyone wants to talk about pain, and I'll talk about pain next, I think the big one is morbidity, comorbidity. Multimorbidity, multiple comorbidities is way more prevalent in women than in men. The presence of comorbidity significantly ups the disease severity score and the likelihood that they're not going to respond to therapy. This has been seen in psoriatic disease and in rheumatoid and a number of different disease states. Having comorbidity, regardless of your gender, really worsens the outcomes. And women have more comorbidities overall compared to men. So again, women tend to have higher rates of depression, anxiety, FM, OA, OP, right? In RA patients who are women, they tend to, actually have worse disease activity scores. While men may have more nodules and extraarticular manifestations, women have more erosions. What do you want, a nodule or an erosion? I guess if I have to choose, I'll take the nodule, and live with the bump. And lastly, women tend to have poor outcomes with regard to response to DMARDs and biologics. Everyone gets around to pain. Pain's important, and you can quite simply say that women are more sensitive to pain. It's not quite so clear that women have lower pain thresholds. If you read the pain literature, it's kind of all over the place. And I think that the pain experts like to get themselves all confused by their own literature. And so they overcomplicate things in my view. But nonetheless, they can't quite agree on pain thresholds. On one hand, they say women must have higher pain thresholds because they endure childbirth, whereas I just compared that to man flu, which is, the sniffles that is debilitating. And on the other hand, women are more likely to complain of pain and actually have higher pain scores. Clearly, there are gender differences in pain. Everyone agrees that there are major gender differences in pain. Depends on what you're measuring is the problem. So while men are supposed to endure the pain, women, and probably complain about it while they're enduring it, women are more capable of adapting. But women tend to carry more pain when you actually get down to measuring how much it is they have. But then again, pain severity is supposedly equal between the sexes. Yet women have more pain, yet women are more sensitive. You see what I'm saying? It gets really, I think, into a semantic and confused discussion. Clearly, women are more sensitive to pain. Women have more chronic pain than do men. But the severity thing doesn't really hold up. Another one of the final factors is pregnancy. Pregnancy not only ups the ante, ups the hormone changes, and interestingly, talking about pain, a woman's pain and pain thresholds, they change in the course of their monthly cycle. It's higher with luteinizing hormone and again, things I don't really want to get into, but it clearly varies on a month-by-month basis, and women know that. Men don't really know that as well. Women, we have usually the same kind of pain until, our favorite sports team, loses a playoff game. Then we're devastated. Lastly, I think timing is an issue. Women tend to have earlier onset of disease. They tend to endure disease without complaint, and then they tend to be diagnosed later. There's a lot of literature, more recent literature is not quite so bad, but a lot of literature that's 10 and 20 years old shows that women are less likely to be referred for an autoimmune diagnosis and for treatment. Lastly, I'll say that there might be an upside to being a woman when it comes to these issues. Life expectancy is far greater with women than with men. by as much as 4 to 5 years, and that's been steady over the last several decades. Maybe the reason for this are multiple. Women tend to have higher HDL levels than do men. And there's a lot of confusion about whether women have more cardiovascular deaths than do men. I don't want to get into that one. I just know the HDL difference is pretty consistent. Women are more likely to have stronger social networks and support systems than do men, and that's probably another reason for their longevity and their durability in coping with the pain and difficulty they have. Whether or not they have less stress because of this is a little less certain, but that's also pointed to. And so, again, the last issue is that men are the worst at seeking medical care, whereas women are more likely to deal with a medical problem or symptom, and hence they get dinged for having more complaints and more medical visits and whatnot. But like I said, in the long run, they actually cost the healthcare system less money. So these are many reasons why there are gender differences. Be sure to look at the other videos and see what our other contributors are saying about this topic. Hope you enjoy this month of Women in Rheumatology.